Good morning, respected my mentors, seniors, and my dear colleague. So today I am going to present on vascular challenges in pancreatic surgery. So the outline of my presentation is the normal anatomy and this gastrocolic trunk of Henle configuration, which has to be slow and steady dissection. That's the tiger hunt, what I call. And the next is the ischemic portal vein, the guide to onsenate, the soul of Whipple procedure. The most difficult part is the onsenate dissection. So, and the next is the first jejunal vein and the jejunal trunk configuration. So that is, so you have to be steady in that, and also, so if you injure that, then there will be the bowel this congestion and chances of POPF. So next is the IPTA. So that's the Achilles heel. So if there is a bleeder, then it will be hard to control and it will ruin your dissection. And next is the configuration of this reflex right hepatic artery, CHA, the SMA first approach, and why it is more crucial. So I'll be talking about that, and the reflex GDA, where to find, and the ligation, the point of no return. So this is the master key. So when you ligate it, and if there is no pulse at the proper hepatic artery, then what next? So I'll be talking about that. So next is the celiac artery stenosis. So how to diagnose it, pre-F, and if there is no intra flow through the CSA, how to tackle it. So next is the portal vein resection. How far can we go, and how far can we do the resection? And the next is the concept of major pancreatomy, the triangle operation, and this PSL3, the arterial divestment and arterial resection. So what's the goal of doing it? So next I'll be talking about the body of the pancreatic CA. So in this I'll be talking about the modified apple bite, that is distal pancreatomy and celiac axis dissection. So how to manage the ischemic gastropathy and the concept of turbocharging in it. So these are my outline of my presentation. So talking about the main, the anatomy itself, the pancreatic blood supply. So it has a chief branch from the celiac axis and the SMA. So here it is supplied by the branches of GDA, which gives the anterior superior the pancreatic artery and the posterior superior pancreatic artery, and whereas from the SMA it gives the anterior inferior pancreatic artery and the posterior inferior pancreatic artery. So it forms the one arcade. And the next for the body and tail, so it is given by the splenic artery, the branch. So there is a dorsal pancreatic artery, which is the soul of supplying for the splenic artery, and it gives both right and left branches, and from here it forms the arcade as well up to the tail of the pancreas. So next, talking about the normal anatomy. So on the right of the presentation slide, you can see the celiac axis, it gives the CHA, splenic artery, and the left gastric artery. So from the this common hepatic artery, it gives the GDA, and from where it gives the right gastric cloac artery, and also from this like splenic artery, it gives a left gastric artery. It forms the arc of this Burko, which is so one of the arcade that forms. It also helps in the conduit formation and this like soft mucosal blood supply for the stomach conduit in the spasectomy as well. So next is the from the splenic artery, it gives a dorsal pancreatic artery. From here, it supplies the right transverse branch, and also from this superior pancreatic artery, it gives the posterior superior pancreatic artery. So it forms this Kirk's arcade. So in this way, it forms this pancreatic arcade. And the next from the IPDA, it gives posterior inferior and this anterior inferior this like pancreatic artery from here. So next is the arc of Buller, where so this is one of the aberrant vessels. It only is seen in the 3% of the population. So it connects the celiac axis and SMA. I'll be talking about this in the following slides. Now So going to the Henley's trunk. So Henley's trunk is the concept of Henley's trunk was given in this 1868 by the Dr. Henley, where it was the bifurcation forms by the right gastrocolic vein and the superior right colic vein. And then after the 5 decades, then the endosurgeon just comes, he identify the another vein, and that is anterior superior pancreatic vein. So that forms the trifurcation, and it gives the proper Henley's trunk, which has a trifurcation configuration. So in these 2 slides, in these 2 pictures, we can see the one was the article written by the pancreatic surgeon, and the next by the colorectal surgeon. So in this, we can see the configuration and the types. The most common types is the type 1, which is around 40%, and here we can see the proper trifurcation. And and the other one, so you can see there are multiple variants in the 6 types, and the next is on the right side you can see the configuration as well, and there is also the combination of right gastrocolic and anterior superior pancreatic vein in the type D, and also in the type C there is a right gastrocolic vein and anterior superior pancreatic vein plus superior right colic vein and the middle colic vein itself. So there is lots of puzzle how to separate this and how to dissect this, because if you injure any one of it, then so there will be the colon congestion. So in this diagram, you can see the most common configuration is right gastrocolic vein, this ASPDV, and superior right colic vein, which is the main configuration, followed by others. So the importance I have told you. And the next is so it is also called the reputational ruiner of the new consultant of the registrar, because the interpreted anatomy of Henley's trunk is challenging, and it has a fixed position, so it is easy to tear on the tissue handling. The variable communication of the combination of the tributaries, which makes it difficult to predict its course, so it leads to the increased incidence of the bleeding and the complications as follows. So now going to the first jejunal vein and the jejunal trunk variation. So we can see it here. The first jejunal vein, so it can come either anterior or the posterior of the SMA. So in the first picture you can see, so that is the ideal configuration, where the first jejunal vein is posterior to the superior mesenteric artery, and in the other one you can see the ventral like jejunal trunk, and you can see the dorsal the jejunal trunk. And also there are few variation in this. You can see both ventral and the dorsal configuration. And in this, what I've found in the literature is that when you have this like dorsal configuration, and then this this middle colic vein will like drain into the SND. And also in the next, if you have the dorsal configuration like ventral configuration, it will drain into into the splenic vein. So next is the formation of SNB and portal vein. So in this you can see the union of ileal and the jejunal trunk forms the SNB, and it is retropancreatic. So you have to define it while doing the on-scenario dissection. And usually the first jejunal vein, it travels the superior mesenteric artery in the most of the cases, which is the dorsal group, and the next variant is the anterior group, which is found in 13% of the cases, which is the ventral group. So now coming to the variation of IMB and MCV like drainage. So in the left photo you can see in the first type the inferior mesenteric vein is draining into the superior mesenteric vein, and in the second configuration the inferior mesenteric vein is draining to the splenic vein like proximally, and it is forming the portal vein. The next configuration is splenic vein, the inferior mesenteric vein and superior mesenteric vein having this like trifurcation, this configuration and formation of the portal vein. So this is one of the variation of the inferior mesenteric vein. So next is the middle colic vein. So the middle colic vein has usually two variants. One, it can drain into the SMB from the left side, and the next it can drain into the splenic vein.
First seasonal vein.
Into the splenic vein. Into the first seasonal vein. So which is the ventral one. So now the configuration of the first seasonal venous trunk and the first seasonal artery. The first seasonal vein usually travel posterior to the supramesenteric artery. So as I explained earlier, and so it has the multiple names. Sometimes it is defined by the first seasonal venous trunk or the first seasonal vein, and the others, the trunk formation are defined as second and third or multiple this configuration. So from the J1, that is the first seasonal artery, and next is the directly from the SMA. You can see in the second one, and next the branch from the replace hepatic artery in the third case you can see, and the next is there are two IPDA. You can find one from the first seasonal vein, other from the SMA directly. So these are the anatomical variation of IPDA. So you can see, so while you are doing the on-site dissection, so you need to delineate the anatomy well. So you need to trace the IPDA and first seasonal artery to its course, and then after that you need to sacrifice the IPDA. So in the next slide you can see the regional trunk division and the bowel congestion. So interpretively, if there is so if you have to sacrifice the first regional vein, so there will be the bowel congestion, but there will be no ischemia, and so it will lead to later on it can lead to the anastomotic like dehiscence or POPF in this case. So next is the anatomical variation. So in the next, you can see the common trunk of the IPDV and first seasonal vein. So the first seasonal vein, it has so multiple configuration. In this, you can see there is a common trunk of IPDV and the first seasonal vein. So in this, if you ligate on the root, then you will face the bowel congestion. So for this, you need to ligate the IPDV separately and let the first seasonal vein so run on its course and drain to the SMB. So next is the first seasonal vein and SMA. So there are three types you can find the relation of the first seasonal vein and with the SMA. So one, it can be dorsal, and the next it can be the ventral configuration, and in the second you can see there is both type, dorsal plus ventral type. So it has a different configuration. So in the picture B you can see the first seasonal trunk regarding the number of jejunal vein. So now the name so name given here is the jejunal trunk. In that you have the multiple vein like draining into the SMB, and the most common configuration is in this article it shows the 2 or 3 configuration and draining into the first seasonal vein. So next, coming to the here classification. So that is the types of hepatic artery. So there are these 5 types. So in this you can see the one is the normal type that we usually encounter, and the type 2 is the replaced one, where so replace our accessory left hepatic artery from the left gastric artery. So that is also you can commonly found it. And the type 3 is the apparent the replace accessory the right hepatic artery from the SMA. And type 4 has the double replace system. In this in the type 4 there is a double replace system. So one for the RSA and next for the LSA, the RSA itself. And then the type 5 is the common hepatic artery that is replaced from the SMA, and the left gastric artery and CHA you can see in the figure itself. So this is the common hepatic artery. So this is the diagram showing the same thing. So one is the replace CHA from which is arising from the SMA in the figure A, and in the B you can see the replace RHA arising from the SMA, and the C you can see the accessory RSA arising from SMA. So there is the accessory RSA, which caliber can be minute in the CT. So you have to have the preoperative CT assessment, and you can delineate the accessory RSA while the dissection course. And the next in the D you can see the replaced LSA from the LGA in this, and likewise in E there is accessory LSA which is arising from the LGA, and F there is a RSA and LGA from the SMA and LGA. So these are the course, and in the G you can see the RSA and LGA from the SMA and LGA respectively. So H is the replaced right hepatic artery via SMA, and the accessory left hepatic artery via LGA, which can be identified after one lateral cochlearization. And in the I, there is replaced CSA, the total replacement, which is arising from the left gastric artery. This you can see in the type I. So in this you can see the aberrant right hepatic artery, which is originating from the SMA in this configuration. So now talking about the vascular anomalies on the pancreatic during procedure. So what is found in this is that when you encounter the vascular anomaly, there is more chances of bleeding and the intraoperative the complication that you can face because of the bleeding. And the others in the other slide, it can like it says in this article that the anatomical variant group with number 41 patient and control group 41 patient. In this you can see intraoperative bleeding is more in the anatomical variant group. However, there is no any bilioenteric leak in both groups, and the post-pancreatic hemorrhage is comparable between the two groups, and the post-pancreatic fistula is slightly higher in the control group, and delayed gastric empty is also comparable. And other complication like intraabdominal abscess formation, it has shown so more in the control group than on the anatomical group, and rest are also comparable. So now talking about the NCCN guideline on the resistability criteria. So the NCCN guideline as per the location of the tumor, the pancreatic head, pancreatic body, and tail. So if there is localized tumor, then it is like resectable. And in the main issue is with the borderline resectable. In the CSA abutment or encasement and no encasement to the celiac axis. So this is also borderline resectable. In this you can either go for neoadjuvant and go for dissection, or you can sometimes attempt the trial dissection up front. So next is the locally advanced, where there is like 180-degree abutment of the SMA or any celiac axis abutment or the aortic invasion, which are not resectable. And for the vein you can see in this like main portal vein or SMB encasement with the reconstructible MBB and the SMB. And in the local advance there is you can do the do the reconstruction of the venous structures. So for the pancreatic tail, body and tail, it's same thing, but the SMA like degree of the encasement is less than 180 degree, and in the local advance there is more than 1 degree for SMA or CA abutment, and also for the venous is same thing. So this is one of the famous the classification of portal vein SMA involvement. This is Ishikawa classification. In this, in the pre of CT also you can delineate this, and you can plan your surgical dissection. So A is normal. So in B there is smooth sweep without narrowing of the portal vein SMB confluence. And in the C there is unilateral narrowing, and in the D you can see bilateral narrowing, and the E there is bilateral narrowing with collateral formation, that is because of thrombosis or something. So portal vein resection types. So portal vein resection type, it depends on the degree of the venous involvement and the site and also the segment involved. So in the type 1, in the portal vein resection, so you can do just the venography, that is enough. And in the type B, you can do the patch. So for the patch, you can use the graft, so which can be autologous or from the artificial graft, which I will talk later on. And for the segmental resection in the type 3, you can still do like into-vein anastomosis with or without preservation of splenic vein. So for this, so you have to do the mobilization, and when there is still you have some difficulty, then you can also do the mobilization of the liver, and when you do the liver down, then you can easily do the anastomosis, into-vein anastomosis. And the type 4 is is the difficult one. So where you you need to do the graft interposition. So in this, so your surgical planning would be either to include the splenic vein or not, or the reposition of splenic vein for the graft. You can do both. So now talking about the celiac artery, this stenosis. So the incidence is about 7.3% in this article, and the collateral arteries like pancreatic arcade, 95% of the cases is well formed, and the dorsal pancreatic artery also 76% of the cases are well formed. And the main cause of this cause is the median arcuate ligament syndrome, and next is the atherosclerosis. So you have to do the well judgment pre-op with the imaging test. Which is the separation. So like GDA clamping before separation is before ligation of the GDA, which is the gold standard for accurate identification and evaluation of this phenomenon. And before dividing the GDA, they clamp the GDA first, judge whether there is inflow in the proper hepatic artery or not. You can do the judgment with the palpation of the pulse. Next, you can do the vascular Doppler ultrasound. The two modality you can use for the GDA after GDA clamping and see the flow. So there are two main reasons of the celiac artery stenosis. So one is the median arcuate ligament syndrome. In this, the blood supply decreases after occlusion testing, and the division of the median arcuate ligament can be done, and which is the first step in the management of celiac artery stenosis. So what the literature says that there is the success rate of around 87% after the median arcuate ligament division. And if the blood flow is not recovered even after the division of the median arcuate ligament, then what next? There are options of revascularization and preservation of the collateral artery should be done. And for the atherosclerosis, it has to be diagnosed preoperatively, and if it is diagnosed preoperatively, then your plan could be endovascular stenting or balloon angioplasty, which can be done. And if it still it is intraoperative, you face this complication issues, then you can go for revascularization option. So for this, you have the arterial reconstruction, which can be done which can be performed from the aorta to the celiac axis, and the next could be the splenic artery and SMA bypass can be done between the abdominal aorta and CSA. So there are these two options you can do. And the next is the GDA clamping. So now, how it works in the setting of celiac artery in stenosis is that the original celiac artery blood supplied by the in the retrograde fashion from the SMA by the GDA through the pancreatic artery or dorsal pancreatic artery, which usually goes in the compensation and to the retrograde flow, and from here the blood will goes to the proper hepatic artery, and the liver will get the flow. And during the pancreatic surgery, so when you are doing the Whipple's, the GDA and pancreatic artery will be ligated, and this breaks this compensatory pathway. Then you will fall in the trap. So if it affect the blood supply of the liver, stomach, and spleen, especially the your biliary anastomosis and the PJ, then there is a risk of ischemia and the anastomosis breakdown. So one is the arc of Buehler. When there is celiac artery stenosis, so you can see there is incidence of around less than 5% of the patients that can have this arc of Buehler, which is the rescue. And when there is aberrant arterial anatomy, the arc of Buehler provides the alternative flow that would be the anterograde flow from the SMA to the CHA, which is maintained, and from there, even if you ligate, then it will give the like collateral flow to the liver and with these vessels, and so that will prevent from doing any like intraoperative reconstruction or any intervention like pre-op or intra-op. So this will be just time saver. So next is the hepatic artery like configuration, and the Michaelis, the classification of hepatic artery variation was published in 1966. It divides into 10 types, and some variants of hepatic artery can be found in preoperative CT scan, but some variation cannot be found because of the blood vessels are too thin. Therefore, while doing the this pancreatitis surgery, you should always be vigilant and confirm the configuration of all arterial branches of the hepatoduodenal ligament to avoid unnecessary arterial injury. So this is the hepatic artery configuration. You can see the most we encountered the normal variant is around 55% in this like article, and the replace LHA from the LGA is around 10%, and replace RSA from the SMA 11%, which we also encounter very often. And the next is the necessary LSA and RSA, which is around 7 to 8%, and the next, the rear one is the CHA from the SMA, which we have encountered in our dissection as well, which is around 2.5%, and CHA from the LGA, which I haven't seen, and which is around 0.5%. So in the Whipples, the variation of RSA is most relevant to the surgeon and like during the surgery. So if there is the variant of the right hepatic artery originating from the SMA and the celiac axis, even the whole CSA or the PSA or RSA may be originated from the SMA. So it can be easily damaged during surgery. So the approach that you are doing the dissection and very cautious dissection while you are doing the posterior dissection or your onset dissection, that is that we should keep this variant in mind. So variant of RSA is located behind the head of pancreas, often accompanied by the tumor invasion. So this is one scenario. In this you will fall in the trap. So where the tumor will engulf your artery, or it will be totally encased, and it will be difficult to separate. And so what next in this situation? So in this. So regardless of any situation, when you have got your RSA during the Whipple's procedure, then you need to remove the, so it is required to remove the variant of SMA by tumor invasion. So in this case, what the article says that when there is the distance between two inner arteries can be anastomosis if it is the distance is less than 2 centimeter. You can do in-tune anastomosis in this actual situation. If the anastomosis is not possible, then what next? Then you have two options. One is arterial transposition or arterial bypass may be used. So at this time, the effective method of arterial transposition is to retain the GDA stump. If you have a sufficient length of GDA, then you can anastomose with the distal dissection end of this replaced right hepatic artery after transposition along the hepatoduodenal ligament. So this is one like tips and tricks that you can have in your mind while performing the surgery, and if your RSA has been engulfed by the tumor. So next is the reconstruction tips. So if the transposition is not possible, then what next? The residual GDA and the distant variant of RA are anastomosed together by the arterial bypass. So if the size of anastomosis doesn't match, then you can go for into-side anastomosis, can also be used. So if the caliber of the vessels do not match, then you can go for into-side anastomosis. So the selection of the transverse arteries can be determined according to the actual situation during surgery. For example, if you are using the splenic artery to transpose and reconstruct the CHA or SMA, and you use the dorsal pancreatic artery or the right gastrocolic artery for the transposition as per the caliber of the vessels that you are and that you have encountered. So in this image, you can so clearly see the trap that you have like encountered here. So in the picture here, you can see the variant of RSA has been embedded by the tumor. So in this, the anastomosis between the residual GDA and the distal RSA, like direct like anastomosis or vascular bridging can be done in this case to augment the flow to the liver. So next, if you have a tumor along the body or tail of the pancreas in the celiac axis, then what next? When tumor invades the CHA celiac axis, then needs both resection and reconstruction of CHA, and the surgical method is like distal pancreatomy or total pancreatomy. So at this time, the right gastric plaque RGA or the left gastric plaque or right gastric artery was always disconnected, and you need to pay attention to the blood supply to the stomach. So you should keep one artery, so that could be the left gastric artery. So if you have the left gastric artery, then you can do anastomosis and augment the flow. So in this you can see the tumor doesn't invade the GDA, so GDA is free. So there is so like you should not ligate the GDA, and when there is the LGA remains is there, so you have the LGA here, and which does not affect the blood supply to the stomach. So in this case you have the supply from the this GDA, and the next scenario is this. When tumor invades the GDA and like GDA needs to be ligated, then what next? So if you have right gastric plaque artery cannot be preserved when GDA is also disconnected, then celiac axis is recommended to be severed at the site of so at the site. So like at this site you need to like disconnect the celiac axis, and then the celiac axis and the common hepatic artery reconstruction can be performed with the stone that remain here. And the next, if the right gastric plaque artery is preserved when GDA is disconnected, then celiac axis can be severed at this either at the site 1 or 2. So you have two options to sever the like celiac axis. So in this, the celiac axis and the CSA reconstruction can be performed in this way. There are two ways you can do it. So now the trap is when both arteries and vein got invaded, then what next? So to avoid, so when the reconstruction and like dissection or reconstruction of artery and vein both require because of the tumor invasion, the operation is difficult and takes a long time. So to avoid this disadvantage, because of the too long portal vein blocking time, so you can do the procedure that could be measurable shunt in this. And so next you can do the venous graft interposition from SMB to portal.
Start. Camera on the burger.
So it's like you got the two options. One is the measurable shunt. Next is the venous graft interposition from SMB to portal vein. So there are two options when you have both artery and vein got invaded, and you need to do the shunting. So next. So in this figure, so it has been depicted. So you can see in the first where the inferior vena cava and the left renal vein and there, and the tumor has engulfed the SMB portal vein complex, and the tumor is divided so below at the SMB, and you can see the SMB has been shunted to the inferior vena cava. So in the next picture, which is not shown there. In this, after PD surgery, when SMB in this the segment of SMB portal vein complex has been like divided, the tumor is removed, and in this the graft has been interposed between the SMB and portal vein. So this is the two way you can manage this sort of scenario. So next. So now the selection of bridging vessels for vascular reconstruction. So there are plenty of options. The first preference is the autogenous vessels. That could be the intrajugular vein, like the greater saphenous vein, left renal vein, femoral vein, external iliac vein, gonadal vein, inferior mesenteric vein, and splenic vein. But however, the left renal vein is easy to expose during the abdominal dissection, and it is not require any other additional incision. And in this also you can preserve the adrenal and gonadal vein as well. So you can achieve the adequate length. And also the vascular patency of the left renal vein in this article shows 100%. So the next option that you have when you run out of these options where the situation is not favorable, or you just need to just do the patch repair, then you can use the parietal peritoneum or the falciform ligament that can be done to bridge the blood vessels. And the next option is the PTFE graft, and the next is the bovine pericardium. But for this you need to use the blood thinner after use of it. So now coming to the major pancreas, the evolving concept of the total major pancreatic excision. So the concept of this major pancreas was given by the Kokel as at 2007. So it was the same as the concept given by Bill Hilt in the 90s. So the concept of major pancreas is that the perineural lymphatic layer located dorsal to the pancreas, extending from the posterior surface of the pancreatic head to the mesenteric vessels, that is SMB or SMA. So these perineural lymphatic layers are actually the tissues that holds the pancreas and that lies behind the head, and that is connected to the SMB and SMA. So these are the perineural lymphatic tissues, and so it was further refined by the other surgeon, which is the peripancreatic fatty tissue posterior to the pancreatic head and lateral to the SMA. And at the 2012, the RM et al. Gave the concept of triangle, which is the posterior surface of SMB and portal vein, and anterior surface of the aorta between the celiac trunk and origin of the SMA. So that is the retroportal lamina. So retroportal lamina that is extending up to the aorta, and the lateral boundary is limited by the semicircular semicircumference of celiac trunk and SMA plexus. So that is the concept given by him. And the next is the Kawata at 2012. He came with the cluster of the soft connective tissue along the IPDA and first general artery. So that is extending towards the major jejunum, and which is circumferential tissue of SMA. So that is the concept given for the major pancreas. And now in this you can see the level of major pancreatic dissection. There can be level 1, level 2 and level 3. So level 1 is not recommended, that is usually for the benign disease. For level 2 and 3, and when there is in the level 3 you can see when there is invasion to the pancreatic ductal, when there is invasive ductal carcinoma of hair or ampullary CA, then it's recommended for level 3. So in the level 1 you can see the dissection of the simple major pancreas division without the lymph node dissection, preserving the plexus around the SMA and the jejunal artery and the jejunal veins. There is no dissection on the left side of the SMA, and major jejunum can be preserved. So this is usually done for the benign disease. And the next is So in the level 2 dissection, there is an in-block lymph node dissection in the major pancreas by the central basal ligation technique. In this, you have to ligate the IPDA at its root. So the dissection corresponding to the lymph node and major jejunum. So it will extend up to the major jejunum, and you have to central ligation of the vessels. So in the level 3, the in-block major pancreas dissection with the right hemicircumferential of the SMA dissection. So you have to do the hemicircumferential dissection of the SMA from 6 to 12 o'clock, and so it is 180 degree dissection, which is the hemicircle from 11 to 5 o'clock it says, and peeling the SMA along the plate, and the dissection along the SMA and corresponding to the major jejunum is also resected. So it is resected up to the major jejunum. So, so there is the concept given is the triangle operation, which is given by the Hacker et al. From Germany, the Heidelberg triangle, which you can see in this picture, and there is the plexus you can see along the SMA, and plexus along the common hepatic artery and the CSA, and this is the apex of the triangle, and this is the portal vein SMB complex, and where you can see the extension of this like neurolymphatic tissue. And so this is the triangle concept, and it has to be clear in the locally advanced pancreatic cancer, which was given by Hacker et al. At like 2017, and it's goal. So now coming to the concept of periarterial divestment and the resection. So the concept is to the goal is to achieve the negative margin. So in the locally advanced pancreatic cancer, the tumor will there is the tumor extension of the adjacent visceral arteries, and the periarterial divestment, where there is you will find the plane of dissection between the arterial adventitia and the surrounding perineal tissue. So this concept was given by Mayo et al. 2016, and later on the aggressiveness of surgery has moved forward, and the Kao et al. Gave the concept of sub-adventitial dissection. So you can see in this picture the plane of the periarterial this divestment, and the sub-adventitial this divestment. So you can see the elastic lamina, which is well preserved internal, and the external one you can see in this, the external one lamina is like stripped. And so like this approach, the management of tumor extension to the visceral arteries during the pancreatomy agent to be able to safely resect and reconstruct the celiac and hepatic artery when necessary. So the configuration is first you can go for triangle operation, which is equivalent to the periarterial divestment, and the next next is the sub-adventitial divestment, which is more deeper. And when there is frank involvement of the vessels, the next option you can have is the resection and reconstruction of celiac artery or hepatic artery when necessary. So in this periarterial divestment and sub-adventitial this divestment and arterial dissection, so in this figure you can clearly delineate the concept. So so there is a grading. When there is no invasion of the tumor, then arterial dissection was expected, and you can do with the plane in between, so no need to go through the periadventitial tissue. So in the grade 1 you can see the tumor invasion of the tunica adventitia. So your goal is to achieve the 1 mm margin, at least 1 mm margin, and for the arterial dissection, which you can do with the sub-adventitial divestment. And the next is the grade 2, the tumor invasion to the tunica adventitia less than 1 mm, and the artery elastic lamina and R1 resection was expected with the sub-adventitial divestment. So in this case, you need to expect with the arterial divestment or arterial dissection is needed. And in the grade 3, the tumor invasion to the external elastic lamina, the arterial dissection was needed, and or the case is irresectable. So these are the approach for the arterial involvement. And the complication that you face after doing the arterial divestment is there will be the chyle leak and the diarrhea. So so now expanding the indication of arterial involvement and the surgery, the next is the arterial dissection and reconstruction. So what are the options that you get for the reconstruction? So in the figure here you can see the basic anatomy and the relevant vessel of SMA like dissection. So in type 1 like B, you can see you can do direct into anastomosis. And type C, you can do the transposition of ischemic artery of the same caliber and with the distal stump to the SMA. You can do that. And the type D, you can do into anastomosis with the graft interposition. Now comes the role of graft, where there is a larger gap, and the graft interposition from the aorta to the distal stump can be done. And in type F, that is a more complex dissection, and where is the combined dissection and reconstruction of hepatic artery and SMA using the interposition graft. So these are the options that you go for arterial this dissection and reconstruction. And now moving to the tumor of body and tail of the pancreas. So for this, the option is modified Appleby procedure, which is initially the Appleby procedure was done for the advanced gastric cancer, and now it is like modified. So you will see the preserved flow through the GDA. So there will be the retrograde flow from the GDA, which is preserved, and you can do the celiac axis dissection in this case. So the complication that you face with the distal pancreatomy and celiac axis dissection is the pancreatic fistula, because your stump will be bigger and there will be more chances of leak. And the next is the ischemic gastropathy that you face, and the next the diarrhea. And if there is any like stomach involvement, then you should go for the total gastrectomy rather than doing the distal subtotal or like subtotal gastrectomy, because with that there will be more ischemia of the remnant stomach, and there will be anastomotic leakage. And the next is the modified one of this like modified Appleby procedure. In this, if you have a clear plane with the LGA, and though you like it the celiac axis, then the LGA can be either you can do the ischemic preconditioning with embolization of the LGA, or next is the concept of supercharging or turbocharging. You can do the LGA preservation, and you can implant that. You can do that to prevent the ischemic gastropathy. So next is when there is a tumor at the neck of the pancreas, and there is the venous invasion, then what next? The goal is always the R0 dissection. So you can expand your limit of the dissection and do the venous dissection in this case as well. So it is known as the Whipple's at the splenic artery, the concept given by the Starbucks as around like 2012. So in this, there are different zones of venous involvement you can see. So one is at the hepatic hilum, 2 is up to the hepatic duodenal ligament, and 3 is the splenic portal vein confluence. And the 3 has different types. It on the right side or on the left side of the venous confluence of the tumor involvement. And there is zone 4, which is actually inferior to the iliac or jejunal branches. So in this, still the resection is possible with the adequate margin. So according to the types involvement, there are different options you can do. So the procedure performed is for the hepatic hilum is the liver resection and interposition graft into in or patch repair can be done for the vascular reconstruction. So which is the backup with interposition graft always in all the cases. And if there is hepatoduodenal ligament involvement because of distal cholangio or pancreatic head tumors, then you can do the Whipple's, and for this you can do into anastomosis, or you can do the anastomosis or the interposition graft. And when there is SMA portal confluence involvement by the pancreatic head tumor, you can always go for SMA first approach. You can see the resectability, and you can do this WARSA, the Whipple's over the splenic artery. And you can do either into anastomosis, or you can do the transverse plication or venous patch. And the next is the ramps, where the bend patch can be done in that. So accordingly, so going for the 4th and 5th, that is for the ramps. So in the ramps, the tumor is at the body or tail of the tumors, and there is again the goal is the negative tangential margin. The ramps. There is certain surgical plan and the principle that we follow, need to follow in the ramps. So there is a traditional way of plane of dissection between the posterior layer of the pancreas and the adrenal, and so that is the traditional way. So next is the anterior ramps, where there is so you will feel so you will find the plane between the anterior renal fascia and the tumor in the anterior ramps, and where you will save the adrenal gland. And the next is the posterior ramps, where you will go beyond the anterior renal fascia, and you will take out the adrenal and adrenal vein envelope with it. So limit of dissection is the anterior renal fascia. Then you will encounter the left renal vein and the left adrenal vein, and then you have, if your option is to do the anterior ramps, then you will preserve the left adrenal gland. And if you are going for the posterior ramps, then you need to take out the adrenal gland, where you can depict in this picture. Thank you.
Thank you, Dr. Bigyan. We are very wonderful. You presented a very comprehensively, and you are divided in 3 portions rather than in one chapter. It was a very big topic, so you did very well. The only few things, most of the things have been already said by him. Few things that I want to highlight is, first, he said about the electron is very important. So you must remember how to exactly find the cholesterol. So everybody does. My choice is one technique that I will recommend is successful in about 80% of the cases. 80 to 85 of the cases. Percentage of cases very good. So we do the cattle Brahman maneuver, then you go to the open of the gastrocolon ligament. And the first thing is that you go to the left side of the assembly. So you go to the left side assembly, then you mandate to the over the assembly. Then the inlet trunks either arising in the center or towards the right side. Generally at 11 o'clock position, 10 to 12 o'clock position, generally you find the trifurcation. That you should have the imagination perception in your mind. So at that position you can look at the cholesterol. Trifurcation that he has mentioned is very common. So first emphasis should go that before doing traction, counter traction, anything, first ligate it. Because once the injury to the cholesterol happen, there will be the massive bleeding to the obscure. So take in mind, after cattle brush maneuver, open up the gastrocolon ligament, find out, go to the, this is the assembly, so go to the left side, to the medial side of the assembly, over the lower part of the pancreas, then move and then find out what is the turnover and ligate it, whatever it is. Then only move to the either a classical approach, portal venous approach, or the assembly approach, whatever you use. So in that way, somebody's system is taking the traction, somebody is taking the counter traction, and the patient is fatigue over the geoids. Make it point first diabetes. This is one thing that how to identify exactly the site and the strong. Then he said the appearance of the jejunal arteries. So there could be 1, 2, 3 jejunal arteries giving it to ligators. So nothing much happens if ligate the jejunal arteries. Generally to the J1, and he said quite very well in the picture he showed that IPDA may be arising as a common trunk with the jejunal artery. So it will quite often in the surgery I used to show you that this is the just in with understand the time is too long. The description I wrote down. So for example, this was the SMA, this is the SMA. So if this is the general common trunk, goes like this and J1 like goes like this, the common trunk, which is not IPDA trunk. So you can either ligate here if the margin is compromised, or quite often if the margin is okay, you ligate it deep behind the J1 margin. Right? Which is quite good. This is one of the steps that I can do. The next step I wanted to highlight regarding the GV, first seasonal way. It's also very important how you can do. So the trick for the first seasonal way, like last time Dr. assisted very well the sir, you so last time Dr. assisted very well the proposal. And the video very catchable. I think I will show you the next time how do he perform the proposal. So what he did, the assistant, this was assembly, this was the assembly. I always recommend to the assistant retract the assembly so that the assembly is exposed. So in that way you will find the first in the common variant which goes and loops around the assembly. You will find quite well that the retraction is done by the assistant and the surgeon will find out the branches coming to the uncinate process. Here is the idea is the uncinate process. The branches to the uncinate process will be divided. So that is a very good way not to damage the jejunal, the first jejunal branch arising from the assembly, draining into the assembly. So if it is invaded, that is another matter. So that's one trick how to identify the first jejunal and how not to injure it. Then the most important thing is mentioned about the complications. He said that complications, even if the anomalies are there similar, whether they have the anomalies or they don't have the anomalies, the only thing that you must remember is that you must remember how you have to do the surgery. If you are quite competent in anatomy, you know the structures well, but definitely whether there is the presence of anomalies or there is the absence of anomalies, that is a big difference. That he quite will highlight in one of the articles of 50-50 question, right? 41. So I think that quite very well highlights how good you should be anatomist and surgeon as well at the same time. The most important thing that in the era of people surgery, pancreatic resection, there were 3 eras. One era was the era of resection, resectability. They tried to understand when the tumor is resectable. Whenever there was invading the assembly or portal, they said that it's unresectable. In the era of the LN people, that was considered that was considered the limit. If the assembly or portal vein was invaded, then they will just abandon the question. Then came the era of reproducibility, and the surgeons understood that yes, portal vein assembly is no contraindication, and you can excise them very well. The options he has mentioned already how you can do the resection of the portal vein assembly. Very important thing in that point is one moment that, for example, this is the portal vein, this is the spreading vein, this is the assembly, right? So how far you can dissect it? That's the question. At one point he mentioned whenever it's possible do the venography, that's the first type one, do the venous patch repair. When it is needed to do the end-to-end instrument, 3 cm is quite big. Even 4 cm of the end-to-end sounds can be done, but for that we have to do good lateral birth maneuver so that whole of the intestinal loops are taken to upside towards the left shoulder of the patients. In that way, the whole small bowel mesentery is mobilized. That is how it is located in the abdominal period. Right? From that it happens. So that way, and also the mobilization of the liver is a very important point. Mobilize the liver first time, it gives an extra 1.5 to 2 centimeters of the length. So you can do the end-to-end anastomosis. So that's a very, very good thing. So that was the another thing is that how you can, for example, the veins are, and this one, there's veins, how much you can excise. So the most important thing is even J1, JV1, JV2, whatever veins are there, if they are of the good caliber, and you can interpose or make the anastomosis by some interposition in between the portal vein, that's very important. That's doable. If the branches are too small, or the collaterals have developed, like in the context of the portal hypertension or portal thrombosis, then you should very much be careful because there is a high morbidity and mortality as well. So you should have patent portal vein above, and the smaller branches were put in calibers where you can do the interposition graft in between. If you cannot do this, I think you have to abandon the procedure where there is a high morbidity. Then that was the period of reproduction. Now is the period of recoverability. Which means the patient should recover after any extent of the surgery. Even if the massive surgery, patient should recover, come out of the surgery with good quality of life and good results. So for that, what we should know, that there are several factors. We very much know about the CA 19.9. We say there is more than 1,000 the patients are biological, not good if you do the surgery. But about 10% of the patients are non-secretors. They will have normal CA 19.9, but still carriers have that poor biological factor. Like the US is an negative patient, they will have normal CA 19.9, or even poor biological candidate may have also normal CA 19.9. Or who has got the obstructive jaundice, this CA 19.9 is erroneous. So you cannot rely only on the CA 19.9. Besides that, what is the next important thing is that any sort of vascular dissection, any sort of borderline tumor should not be taken for the surgery as far as the guidelines say. Upfront surgery should not be done. You have to start with the neoadjuvant treatment. So for that, any patient who are fragile, any patient who are above the 75-80 years of age, so you should give time with the chemotherapy. Any patient who have the biological factors, CA 19.9, any vascular invasion. So the results are good if you provide the neoadjuvant chemotherapy. Now, after the neoadjuvant chemotherapy, how we are going to assess that the patient is receptive or not? So is the CT scan? Quite often you will see the CT scan will say that it's still unreceptive. Is it the CA 19.9? No. So what has been said, the PET scan, the metabolic evaluation has to be done with the CT PET or PET MRI along with the CA 19.9. That will give you the better assessment of the functional status or the metabolic status of the disease, whether the disease has regressed or it is still inside you. So whatever the fibrotic lesions is there, you can see still in the CT scan, thinking that with the tumor residue, you can exercise, but actually you can do it. So radiologically, CT is not a factor of the neoadjuvant chemotherapy. So recovery should be based on the metabolic assessment, which has to be done by PET scan along with the CA 19.9. Few things what the choice of the venous graft is said. Just to revise, peritoneum is good for the venous resection. Any blood gas, any surface is good. Left-handed vein he has said is also good. I think the peritoneum is the very simple way that you can do. But for the arterial reconstruction, he mentioned the reverse splenic artery is good, is available. If it's not that available, then the next option would be not the vein. Initially, the saphenous great saphenous vein sometimes matches the caliber of the hepatic artery. You can put that the long duration external loop equal to pulse. It cannot withstand the higher pressure with the formation of aneurysm, etc. So for that purpose, the best would be if splenic artery is not available, then superficial femoral artery. That can be harvested from the same patient, if not the cadaver, and you can use it. So that's the very good option in the case of the artery. Besides whatever he has said, the different thing. Regarding the, I think one last thing that I would like to mention, he said very well when there are several very complex situations in arteries and veins both have to be excised, but definitely it will take longer time. The arteries and veins will be clamped at the last when the most of the dissection has been done, the bowel has been excised or cut, divided, the bile ducts have been divided, the pancreas have been divided, at last when we clamp the veins and arteries, then we push it further. That should be the better condition. But if the arterial complex situation is there, then definitely the mesocaval shunt has to be done, or the splenorenal shunt has to be done to gain the time, because it will take 1 hour, 2 hours of the time for the reconstruction till time the ball will escape, the venous condition will be there. So it has to be remembered also at the same time. So I think these are the things, because there are several things that, last thing that I want to highlight is when there is the complex situation, don't do the weakles, do the total pancreatic. Because on the top of that there, if there is the such complex surgery, if there is the leakage, then patients will be dying. So don't do in a complex situation, do better total pancreatic than the weakle surgery. And also don't take for the arterial reconstruction the vessel. Why I said superficial femoral artery? Because if you are taking the splenic artery, it will have many multiple branches. Okay. And then what will happen is the pseudoaneurysm formation will be leakage from the bleeding complications are quite high if you use the splenic artery. So it's better superficial femoral artery where it doesn't have much branches, smaller branches like the splenic artery. So this must be Sagar if you want to add something. Too long topic is not भन्दै जाँदाखेरि धेरै पनि भन्न सकिन्छ तर चाहिँ I suggest it's very good. राम्रो talk you should have done in 3 parts rather than 1 hour and 1 point. So anyway, congratulations, you have done a good job.